Hi, my name is Andy Cates, and thank you for joining us. Today we're going to do something a little bit different. We've got an emphasis on social science here at CROI. It's a big scientific convention with lots of people in the labs and doing bench and basic research, but not often do you hear the social aspects of things. So we have two experts here. We've got Karine Dube, doctor from University of North Carolina, and from Project Inform we have David Evans. Both experts in the field. So welcome both of you.
Thank you.
Both of you, and I hope you're enjoying the conference so far.
Very much so.
Yeah.
Good. So social science, what is social science? I mean, is that like the same thing where they do the Coke and the Pepsi challenge, or?
In social sciences, we study humans and human relationships. So we're interested in behaviors and what makes people willing to do certain things.
And how would that fit in with biomedical research?
Well, David and I have been interested in willingness to participate in various types of HIV cure studies. So what would make people living with HIV to undergo certain risks to help advance HIV cure science? And what would make them willing to interrupt their treatment to help advance the science?
I could see where that could be very important because, you know, of course we're searching for a cure, but by the same token, people are generally pretty well off and healthy on a stable, HIV regimen right now. So they really don't need to do cure research for themselves, do they?
Most of the benefits accrue to science and to society, so we rely on the altruism of the study participants to advance the science at this time.
Got it.
Yeah.
And with that in mind, what kind of benefits do participants get in cure research? Is there any?
Well, it's interesting. I did an interview a few years ago looking exactly at that question, and there was a guy that I spoke to who had been asked by his clinician to enter a study where he would start treatment right away as soon as he became aware of his diagnosis. And at first he was really trying to process everything, and he wasn't sure. So he read a whole bunch, and he read the informed consent, and he ultimately came to the conclusion that he wanted to do it. And for him, he said, testing positive was such a surprise and such an intense emotional blow. And he said participating in the research for him gave it meaning and transformed it for him. And so I think ethicists would say, is that a benefit? Is that an inducement? Do we want to play on that part of human emotion to get them to enter a study that might have physical risk for them? I think it's a more fluid and open question. I think it's a gray area, and I think social science is really the only way we can answer that question.
So ethically, that could be a very big dilemma. It's not a black and white issue. How do you draw the line, or where do you place the bar when it comes to ethics with situations just like that?
Well, I think it's important to ask the stakeholders what they would view as acceptable risks and benefits in HIV cure studies. And we can use methods of social sciences and empirical ethics to get to some of these questions. The IRB will tell you it's all about the clinical risks.
IRB meaning Internal Review Board?
Institutional Review Board,
Institutional.
yes. People living with HIV who participate in these trials will say they derive tremendous psychosocial benefits from being a part of this study, for being a part of something so big that they can help advance cure science.
Even though it might not benefit them directly.
Correct.
Mm-hmm. Interesting. And I guess researchers may not have the same, the people doing the biomedical research may not have the same ideas as the participants or the stakeholders for this, yes?
There could be differences in how people perceive risks and benefits. So biomedical scientists may view the clinical risks while the participants view the psychosocial, emotional benefits from being a part of the study. So how do we reconcile that is an ethical question.
So I imagine also compensation would fall into this category and come into play here. We don't want to be coercive when we give people, compensation for doing a study, but where do you draw the line there? How much is enough? How much is too much? How much isn't enough?
Right. Well, it's interesting because the large PrEP studies in women in Africa, what we found was that women were pretty good about keeping their study appointments. When you ask them about their experience with the clinical staff and getting the kind of care that they were receiving, they were thrilled. They felt it was amazing, and yet in those studies, the women did not take the pills. And you know, what became really clear for them was they were able to access a level of care for themselves, both, you know, contraceptive care, sexual health care, other kinds of things that they wouldn't otherwise have been able to get in the community. And the thing about it, is that unethical? I would say absolutely not, you know, because the thing is, if you're asking someone to take risks, you also have to deliver a certain standard of care for them. And really, truly emotionally care for them in order to create that safe space for them to take that risk. So is that an inducement to me? No, not necessarily.
Yeah, just good care in many parts of the world.
And another part of it too is if you look at a study that's taking place at 15 sites in the United States, and let's say you do one of the sites in San Francisco, and let's say you get a young gay guy who works in tech and his salary is $130,000 a year, you know, and you know, what would you say? You would say $100 to come in for 2 hours. That's perfectly fine for him. Does that mean that if a woman living under the poverty line in Atlanta, you start questioning whether $100 is okay for her because it's such a substantial part of her income? I would say absolutely not. That's ridiculous.
Yeah, yeah, that's interesting. That's really interesting. So, getting back to the PrEP studies that you were referencing in South Africa, so there were adherence issues, obviously, as you mentioned.
Sure.
Would social science, if it had been utilized responsibly or maybe even at all, would that have potentially improved the adherence rates? Because it seems to me that there was something going on that was missing, that was causing someone to not take their medication. And I don't know that a blood pressure cuff and, you know, taking someone's temperature is going to tell you anything about that. So it has to be something social, yes?
Yeah, and this is why we need to embed social sciences very early on in the translational research pathway so we can understand the behavior of people. So we are advocating to embed social sciences as part of actual HIV cure studies to understand what's really going on with the participant experience in those studies, particularly if we're going to ask people to interrupt their treatment to be part of a cure study, because that is part of the adherence continuum.
Right.
So as soon as they rebound, they will need to be put back on treatment. So we need to understand what's really going on there.
Yeah, and have you seen this in effect yet? Has it been applied anywhere? Have you utilized it in any studies?
We're starting to embed social sciences as part of HIV cure studies. So we are prioritizing different social science domains in terms of understanding the risks and benefits and experience with treatment interruptions at critical time points in the study. So we're really looking forward to understanding the participant experience in those clinical studies.
Where are you getting your information? Are you actually doing focus groups in the community or sourcing knowledge some other way?
We've done a lot of qualitative research beforehand. So David and I have done a lot of work with key informant interviews and focus groups to help inform these social science domains. Most of this work was hypothetical, but now we're starting to embed social science as part of actual HIV cure studies, and we hope that it will lead to better biomedical research.
Sounds like it may. Sounds like it may. So Project Inform has been around an awfully long time, and Cure is more of a recent explosion in research. How has the focus of Project Inform's research, I guess, research ended up changing along with the I'm struggling for words here, but along with the difference between treatment and cure, I guess.
Sure. So, well, interestingly, much of the clinical and basic research that is taking place in the cure arena today was inspired by think tanks that we held in 1990, 27 years ago, 28 years ago now, that was trying to answer the question, okay, antivirals look promising to possibly suppress the virus. But what about someone with a broken immune system that has 10 T cells? Is there any way to restore it? And so a lot of that basic immunological research, we would bring different stakeholders together, including people living with HIV, to answer that question. And so in part, that's a way we've been involved. But the other part of it is we always came from the place of give people the tools and let them make informed choices. That's why our name is called Project Inform. And so we were always about early access. We were always about giving people as much information as they could to make choices. What that meant, though, is that as people who didn't look the same as those who first showed up in the clinics and got tested changed, and as the level of medical literacy was different, we saw our responsibility as something that was a little bit different, in that you couldn't just assume that someone was going to take an antiviral drug that they didn't understand was what it was going to do for them. And especially there was a lot of feeling in various communities that they were poison. And so how do you develop that trust between the clinician and the person living with HIV? How do you, it was interesting because we were some of the first to pioneer the use of peer advocates, to help with adherence and teaching. But one of the things that, was interesting, and then so what social science was helpful, is looking at over the course of time, how does that peer go from being seen as part of the community to part of the service industry? And what does that mean for the peer themselves? What does it mean for their place in the community? What does it mean for their effectiveness at the work that they're now supposed to be doing? And so that was a really interesting question. So once again, all the way along the way, it's about people's attitudes, it's about their relationship to other people, and it's about their beliefs and their behavior.
And are you finding that scientists and researchers in the biomedical field are seeing a benefit to the research trials and protocols that they're doing with this implementation of social science?
We hope so. We hope so.
What kind of feedback have you gotten?
I don't know.
What kind of negative feedback have you gotten? And then we'll go to the positive.
Well, we're trying to be very efficient and very strategic with our social sciences so that we minimize burden while maximizing information from the participants. So we ask biomedical scientists what they would like to know, and we also ask community what they want to know, and the social scientists make it happen. We design the scales, we design the instruments, and we embed social science at strategic time point, so we can answer questions that various stakeholders have. And we are hoping that social sciences will also inform a regulatory pathway towards a cure in terms of what's acceptable risks and benefits for participants.
Yeah. So are you noticing people getting behind this and being supportive of you in this endeavor?
Yeah.
I think that the it's interesting. I would say that most of the scientists that are really behind us are scientists who themselves have worked in the clinic as clinicians and have often had very caring relationships with their patients. And so I think they get it a little bit more, that they get it that they can't just send someone home with a pill and that's where their responsibility ends. And so I think they get it that, even though it's a very early stage, this is a game changer. This is a total shift in paradigm to what we're going to be asking people with HIV to do, not only in the clinical trials, but maybe one day when they have this available to them. And so they do get why it's important to embed this in the research now, rather than waiting until much, much later.
And because some of the sampling that's done in cure research is a little bit strenuous and it takes a long time. It may involve pain, procedures that are seemingly scary, and so I guess it is a good idea to have the researchers kind of meet participants where they live up here.
Right.
So the one thing that I've always kind of found fascinating is there's out in the world there's this thing of there's a cure for HIV already,
right?
And it's just sitting on a shelf somewhere, so that pharmaceutical companies and doctors can make money, and everybody that has HIV is being exploited.
Right.
Well, I've been around this a little while, and you guys have been around quite a while yourselves. Have you ever seen any doctor that couldn't make more money going somewhere else, doing some other form of medicine, and they're dedicating their lives to HIV and the co-infections and morbidities that go along with it. It seems to me that some of the physicians and the researchers are the finest people and most caring humans I've ever met.
Right.
What would you say about that?
You know, I as someone who's been doing treatment education for 27, almost 30 years, we've encountered, having to work with that, for as long as HIV has been around. I mean, certainly at the beginning, many people thought, the government gave us this virus, so therefore, they're certainly going to withhold the cure, because the people that were most likely to be infected were the people that society hated the most. And it's interesting because I hear these words, conspiracy theory. It's even in posters here. Whether people hold conspiracy theories and whether that affects whether they are show up at the clinic, have viral suppression, things like that. And over time, and I've had people really school me, is when you really think about it, think about the Tuskegee experiment. Think about the experiment in Guatemala. Think about these experiments where paternalistic societies run by white men usually saw people of color predominantly as objects, and not as human beings with agency who had a right to make their own decisions. Look at the continuation of systemic racism and the brutal violence upon brown and black people's bodies in the United States. And can you wonder why people would assume that you all, whoever you are,
Yes.
Why would you have my best interests in mind? Why should I trust you to have my best interests in mind? And so I think that's where we need to start, is we should walk in, no matter who it is, and it doesn't matter, white, brown, black, walk in with someone assuming that your experience with the medical industry, with research, with the government, just in your life, may be such that you would have no reason to trust me. And so it's our job to build that trust. And I think social science is the only way we can get there, really.
Yeah, I think social science is a critical buffer and a critical adjunct to ongoing biomedical research efforts, and it can inform the community engagement, community involvement, how we bring the participants and the communities along with us. It can inform the framing of expectations around a cure so that we can avoid these conspiracy theories. When we did our first study, we found that 8% of people living with HIV thought a cure was already available. So that's why we need sustained education efforts around cure research, and this science is incredibly complex, so we need to find ways to simplify it and make it accessible to communities.
Yeah, and I think that the entire gestalt of people of color, when they go to a doctor, it's usually because they've been very ill, and they've been mistrusting when they were well, so they don't go to have preventive care. And privileged white people tend to go and stay well. That's why they get their medical appointments. I go to be healthy, and someone else presenting very late because they don't have the trust in medicine the way others may. It's very problematic, and then they end up in very bad situations. And in the term of, or in the context of HIV, here they may present with very low T cells, a lot of opportunistic infections, and then at that point, medicine is kind of a struggle for them, and it needs to change somehow. So I'm hoping that you and your colleagues are able to have a big impact on that and put a dent in this and start turning these things around.
Yeah, social science starts, it's part of the treatment conversation too. It's part of the treatment cascade conversation, because people who would qualify to be in a cure studies, most of them have to be virally suppressed. So we need to make sure that we are addressing issues along the entire treatment cascade. And we heard at this conference the role of mental health and psychosocial support, and making sure that those needs are met.
But mental health has nothing to do with a virus or treating it, does it?
I think it does.
I ask flippantly.
Yeah.
So getting to the mental health aspect of this conference, what have you seen, what presentations or posters have you seen that intrigue you?
Well, yesterday Dr. Ramian gave a really wonderful talk about the role of mental health in addressing the needs of people living with HIV. It's 50% of the equation.
Yeah. And you, David?
Well, there are so many different ways of looking at it. A lot of the posters in the poster hall are looking at, the impact of pre-existing mental health or continuing mental health issues and substance use on whether people get tested, whether they are virally suppressed, whether they stay in care, why do they fall out of care, and those kinds of things. I think it's, it's such a cluster that you can't pull apart.
Yeah.
And so basically you're going to be asking people who, by definition, there were issues around mental health and substance use that may have led them to become positive in the first place. And so to ignore the fact that that's going to continue to possibly be a problem, not only for individual healthcare, but, through their participation in the scientific process, and one of the things that as science advocates we've been doing for years is trying to break down the barriers. At one point, women who were of childbearing age were excluded from trials altogether.
Correct.
So we fought that. That's opened up somewhat. Then, you would have these antiviral trials, but they wouldn't do drug interaction studies with systemic hormones, contraceptive hormones, oral contraceptives. So essentially, women taking those oral contraception, either they had to do it at risk because they wouldn't know how it was going to affect their bodies, or they had to do something else. And so we pushed them to do those, things earlier. The use of things like methadone and other substitutions for opioid addiction. Once again, we had to push and push and push and open up studies in that way. So I think that's important. But, just the last thing I wanted to say was, a couple of years ago in Durban, South Africa, we had a booth, and we basically asked people one question. If a cure were available today, to you or to your community, what would it mean to you? And overwhelmingly, in one way or another, the answer was freedom. And so when I talk to the scientists, when I have the opportunity in this way, what I tell them is, if you're shooting for whatever it is that you call a cure, and the problem is we keep changing the definition, I would suggest, are you shooting for freedom for people with HIV? And what elements of freedom are you planning to deliver on? Freedom from stigma, freedom from fear, freedom from the worry of passing on HIV to a partner, and whatever that might mean. In some cases it's criminalization, so basically how are you contributing to or taking away someone's freedom? And I think unless we can address the question in that way, I think we're going to lead to problems all along the way. And so, again, that's where social science really comes in.
Yeah.
Wow, that's really good point, really good point. And the word cure, that's been something that's been a little bit controversial. Is it cure the way you cure, I don't know, a common cold? Or is it, remission? What does a cure mean to anyone?
Yes, and there are many different definitions of cure. There are the biomedical definitions, but also what people living with HIV would perceive as a cure or a remission. And social sciences can help understand the role of language in HIV cure research and talking about this. And for example, in one of our study, we found that the word sterilizing cure was an absolute no-no with the community. The word sterilizing should not be used at all because it refers to sterilization efforts, and so we have to be very careful how we use language to describe HIV cure research. And social sciences can help understand perceptions of different stakeholders.
Yeah, that's interesting. Well, so I guess I give you each a last comment. Are there things that we'll do ladies first? Are there things you're working on now that you'd like to talk about?
Yes, we're really excited about the new studies that we'll be launching, and we'll be collecting data as part of actual HIV cure studies. And it's nice to see collaboration between biomedical scientists, social sciences community, and ethicists.
It's a long time coming.
Yes, we need to plan for the long term.
Nice.
Yeah, and I think one of the things that Karine and I are partnering with others to do is most of the social science studies that have been conducted so far, for a variety of reasons, have largely had gay white men who've been positive for a long time as the primary participants. And so the projects that we're working on right now are almost exclusively focused on women of color living with HIV. And that includes not only cisgender women, but through an amazing, fortuitous partnership with Tonya Poteet, who's one of the leading researchers on trans women. We will be doing some partner work on transgender women of color as well. So we're really excited to see where that's going to go.
Wow, it's about time. That's a group that's been ignored for far too long. Time's up, exactly. And actually, time's up. We need to think about going. But I want to thank you both for the interview, and it was wonderful talking to you. And I know that you do tireless good work. You're both amazing at what you do, and the world is better off for it. Thank you.
Thank you, Andy.
Thanks.